My name is Austin. I'm actually a pharmacist. I work just down the hallway here at MUPC. My specialty practice is just in psychopharmacology. And what we're going to talk about today are antidepressants. And I'm going to move pretty fast through a lot of this. So if you have questions or if something I say makes absolutely no sense, throw up a hand. Feel free to ask me, interrupt. And we'll have a couple spots along the way just to get some clarification. So I'm going to move quick, particularly through the first stuff, because I really want to get into the drugs. So you guys can all read objectives. We're going to talk about depression. We're going to talk about antidepressants, the role of antidepressants, how to design and implement these different drugs, and kind of what the different nuances between them. So how do I pick one antidepressant over another? When is this a good choice? When is this a bad choice? And talk a lot of that in fairly good detail. So depression, as I'm sure you guys are all very familiar with, is probably the biggest mental health problem that we face today. It's about 7% of the U.S. adult population, so roughly 15 million people in the United States right now have depression. We estimate that maybe half of those are being treated, and of the half that are being treated, half of those are being treated adequately. So we're talking about 3.7 million out of 15 million that are actually being managed appropriately. That's why this is a big problem. With the growing shortage of psychiatrists out there, these people are coming to primary care clinics to get managed. I saw a statistic that upwards of 10% of the population is on an SSRI. So whether you want it or not, my patients are your patients. And it's really important that we become familiar with these medications so that we can adjust them as necessary instead of just letting these people roam around at subtherapeutic doses and with still lingering depression, which is a very, very, very morbid disorder. To have the diagnosis of depression, we have to have symptoms present for 2 weeks. You guys all know this. One of those needs to be either the depressed mood or the anhedonia. Then we have things like changes in appetite, feelings of guilt, changes in weight. All of this that gets lumped into it over 2 to 3. My little phone just go out. Let me stand up here. New for DSM-5 is we actually changed it around. We had only a couple different subcategories in the past. We've since split that out, and we now have features with anxious distress, mixed features, melancholia, atypical depression. We used to have just a couple, and again, they decided to tease those out to be a little bit more specific for whatever reason. Risk factors for depression, sorry ladies, it's about 2-to-1 ratio. We see this much more in women than we do in men. There is a little bit of an age association with it. With women, we typically think that it peaks out earlier in life. With men, you can always think midlife crisis. So when we start off, we have the little kids that we see on our child and adolescent unit. Depression is about equal between little boys and little girls. We get into high school, kind of those teenage developmental years, and we start seeing a separation at that point. Once we get up into the 20s, that's where we're definitely starting to see that 2-to-1 separation between male and female. Women are going to peak out 35 to 45, and then it remains relatively prevalent at about that rate. And then again, men much later in the time course of it. Looking at other diagnoses, so the more diagnoses you throw on a person, the more likely they are to actually have depression. That kind of makes sense. If you got more stuff to worry about, more treatments to be on, you're more likely to be bummed out about it. So lots of comorbid medical conditions, particularly substance abuse, pattern of unhealthy relationships being another one that's a prominent risk factor. So why do we get depression? This is called the monoamine hypothesis of depression. It's probably the most widely accepted theory of depression. I'm going to keep this very simple, and we're going to scoot through this pretty quick. So essentially, in its most basic form, we think of synapses. You guys all remember your cell bio stuff. So we have the synapse, which is this little space in between our presynaptic and postsynaptic neuron. And then how are we going to communicate across that gap? We're going to use neurotransmitters. And those are going to float across that small space and hit up with receptors. It's that lock and key concept. You guys taught the lock and key concept. So we have to get right number of keys to go to the right number of locks, and then we elicit effect from it. So kind of amping that up a little bit of a notch is essentially we have all different kinds of locks and all different kinds of keys, right? So each key is only going to work on a certain lock. And what happens is we take all these neurotransmitters or keys, we bundle them into vesicles. A signal is going to come, a stimulus that says, hey, release them. You get enough released out, they're going to float across the synapse, they're going to hit those locks, they're going to turn something on, turn something off, and elicit a response. But that's not all. Because if that was it, then every neuron in your body would fire one time, and then it would be done, and it would never fire again. So we have to have mechanisms of place to reuptake, to break down these keys that got released into the synapse. Most common one, we see reuptake. So we're always dumping out way more neurotransmitters than we would ever need. And essentially, instantaneously, some of those are pulled immediately back in, repackaged, wait for that next signal to say release. Some of them are actually broken down by other pathways such as monoamine oxidase to just degrade them so they're not just hanging out in the synapse. In depressed individuals, we have a lack of keys, right? So we have same number of locks, less keys. We get this kind of rinky-dink response, or in sometimes no response at all. And your brain, trying to adapt to this, will actually start, we think, adding receptors to this postsynaptic site. It says, well, maybe the problem is I just don't have enough receptors to get stimulated. That's why I'm feeling depressed. And so this is called receptor upregulation. And when this happens, that's when we believe depression symptoms start to occur. Now, when you take into account that they already don't have enough keys, and we still have these systems in place of reuptake and breakdown, you can imagine that we have even less at this point. So how are these antidepressants going to work? Probably our most favoritist, which is not proper English, but our favorite mechanism of action is we like to block reuptake. It's clean, it's quick, it's easy, it's effective. So instead of some of that serotonin, norepinephrine, whatever, getting pulled right back in, we can just block that mechanism and more is going to stay onto the synapse. Another thing that we can do is we can actually prevent the breakdown pathways for the different neurotransmitters. And that in and of itself is going to increase the amount of neurotransmitters or the number of keys that are floating around in the synapse. Another thing we can do is design chemicals that actually have a similar structure to these locks that we want to pick on, for the most part. So we can design chemicals that are going to have stimulating effects on these postsynaptic neurons. We can also design chemicals that are going to affect presynaptic neurons. So neurons that are on the firing side. And by acting on these, either blocking or stimulating the receptors, we can amp up that stimulus signal that says release neurotransmitters. Regardless of which mechanism you implement, all of these are going to result in more keys floating through the synapse, going across, hitting a lock, eliciting a response. And over time, since we have all these extra locks on the surface that are all now getting stimulated, your brain's going to say, oh, wow, I guess I really didn't need all of those extra locks. I don't need all those extra receptors. So it downregulates back to what we call normal. And when that happens, we start to see alleviation of a lot of the depressive symptoms. The problem is that's why these medications are not like a Tylenol. This takes weeks to take effect. That's why we start a dose, we titrate it to the appropriate level, and then we tell them it's a waiting game. It may be a month or more. In some cases, it's 8 weeks before we start noticing a true response, improvements in guilt, improvements in suicidal ideation. All of those effects that we would like to fix first end up getting fixed last with these medications. Clear as mud? Okay, moving on. What are the neurotransmitters? So I keep things very simple. In the context of depression, I want you to think about serotonin, norepinephrine, and dopamine. Serotonin, no big surprise, we always think of it as the happiness chemical, right? Plays a good role in mood regulation, as well as memory. Norepinephrine, it's adrenaline, so again, a lot with mood regulation, fight or flight response. Dopamine has a lot to do with reward system in our body. So these are the major players that we're wanting to elicit effects on. Here's our different treatment modalities. And this becomes very difficult because, as you can see, there's quite a few. I actually have a number that aren't listed up here. These are probably the most commonly used antidepressants that we're going to discuss today. So given all those different medications, how do we pick one over the other? Well, there's a lot of different things that come into play. We can look at history of response. There's sometimes a genetic component to it where if mom and dad and sister, brother all did really well on fluoxetine, there's a good chance that maybe you'll do well on fluoxetine. We look at drug interactions is a big part of my job. Is, you know, if I can start you on the perfect antidepressant, but if it's going to mess with your CHF medications, with your COPD medications, with anything else that you might be on, that's not a great choice for that individual. Looking at the different dosage forms of it, is this a medication that we have to be very compliant with? That if we start missing doses, the patient's going to run into a whole lot of problems? Or is this something that they have a little bit more leeway if they're a very poorly compliant patient? We also want to consider things like cost. But most of all, what we're looking at are side effects. So if an SSRI is an SSRI is an SSRI, the question really comes down to, what side effects can I give you? Sometimes we can use side effects to our advantage. Sometimes they can be very detrimental to our patients. So this is a very big component of what I do, is what side effects do I want to give a patient? It's usually not a matter of if they're going to get a side effect, it's which ones are they going to get, and are those acceptable in this particular case? And again, can I use those side effects to my advantage? With respect to side effects, there's a couple other receptors I want you guys to think about. So again, I keep things very simple. And the reason we talk about receptors is because if you understand a receptor, you understand a side effect profile. So when I say something is antihistaminergic, we're talking about histamine 1, right? What happens if something's antihistaminergic? Say it again? Drowsy. Probably one of the most common side effects with it. The other thing that we can get is weight gain. If we have drug A, drug B, they're identical, except drug B is heavily histaminergic, drug A is not. People will tend to gain more weight on drug B because of that histaminergic component. Alpha, specifically alpha-1, if something is highly alphanergic, what happens? If I was on something highly alphanergic, would I be able to stand up here in front of you right now? No, I'd probably drop to the ground. So orthostasis being a big one. Dizziness associated with it. The other thing, muscarinic receptors or acetylcholine receptors. You guys have heard of medications that are anticholinergic. What happens when something's heavily anticholinergic? You guys are quiet.
Constipation.
Constipation. Thank you. What else we got? Dry mouth. What else we got? Blurred vision. Anything else? It's right there in front of you. You can cheat. This is so easy. I gave you the answers. So yes, we see a whole bunch of negative effects with this. You guys have heard of sludge before? Salivation, lacrimation, urination. This is anti-sludge effects. And most importantly, what you don't want to forget are the cognitive effects. What's the geriatric disorder we all think about with a lack of acetylcholine function in the brain? Alzheimer's, right? Or even states of delirium can be equated with that. So you can induce a delirium and a lot of cognitive dysfunction by over hitting your muscarinic receptors. So very important. And the thing about anticholinergic effects is they are additive. So if you have one heavily anticholinergic medication plus another, you have more than that. It's not a fact where you're just going to saturate this out and, oh, well, they're on one heavy one, so this other one won't bother them. No, that's not the case. They are very much additive, and they tend to compound with side effects.